And acalabrutinib is actually felt to be a cleaner, more selective BTK inhibitor. So if you look at the kinome scan, you actually see that acalabrutinib hits far fewer kinases compared to ibrutinib, and the thought is that that selectivity translates into better tolerability, maybe not necessarily better efficacy, but if you're hitting fewer off-target effects, you might reduce some of that associated toxicity. So that has been the story for acalabrutinib development in CLL, where many of those side effects that we see with ibrutinib, in particular the AFib, you still see some, but you see less. In particular, some of the bruising and other side effects, generally all of them appear to be markedly less with acalabrutinib. And what we see in mantle cell lymphoma is also fairly encouraging. We see very, very good response rates. We see a very good complete response rate. And those responses, when we look at the time to event analyses, we haven't reached the median yet for median duration of response, for example. So I think I just started my first patient on this drug last week. And it's a patient that came in with a cardiac history, and you know, why tempt fate? We started acalabrutinib first, and we'll see how that patient does. But for my other patients with mantle cell, using ibrutinib and or lenalidomide plus Rituxan has been game-changing, and in particular, especially for patients with, you know, indolent disease, where you're really trying to manage it with the least toxic approach possible.